Greetings, everyone. My name is Mary Weiss, and I am Vice President of Market Development for Kia Medical. I am happy to welcome you to this SCCT webinar for what is sure to be an interesting and lively discussion about the role of AI in the decision-making and assessment of coronary artery disease, moderated by Dr. Irfan Shafique. Dr. Shafique is a pioneer in cardiac CTA imaging. As a faculty member at Johns Hopkins, he co-developed the cardiac CT practicum, which has trained thousands in cardiovascular CT imaging over the last 20 years. Dr. Shafique continues to teach at the Johns Hopkins practicum and is currently leading the cardiac imaging program at Chesapeake Medical Imaging. Thank you, Dr. Shafique, for leading this discussion.
Thank you, Mary, for the kind introduction. I want to welcome all of you to this wonderful platform, which is provided by SCCT on this educational program. And also want to thank all my panelists also who are joining me on this. I would like to introduce our panelists. We have a great team here today, starting with Dr. Armin Zadeh, who's actually one of my colleagues. He actually is professor of medicine, biomedical engineering at Hopkins, and also is a director of cardiac CT in the main hospital at Hopkins. And he's also a chief editor-in-chief of Journal of Cardiac CT also. Thank you, Armin, for joining us. And my second colleague, Dr. Michael Blaha, who's also actually teaches with me in the program also. He's a professor of medicine and cardiology at Johns Hopkins, and also he's a co-director of the Preventive Cardiology Center there too, and done lots of research in preventive medicine, and also has tons of papers on those things too. Has significant knowledge in cardiac CT too, so it'd be fun to have you on today also. Thank you so much. And last but not the least, Dr. Dinesh, he's actually chief of cardiology at University of Louisville School of Medicine. He's also professor of medicine, and also he's the director of advanced cardiac imaging, lipid clinic also, and he also infiltrative disease, cardiac infiltrative disease. He directs that also, and has done actually quite significant, almost more than 300 articles in research. His main interest actually is interesting is the regression of the atherosclerotic plaque. So we'll hear from him today also, and thank you so much for being on the panel today also. Appreciate all of you joining us today. So we'll start the program, and let me share. All right, so today's topic is AI-derived decision-making and assessment of coronary artery disease. As you know, in the last decade, there has been significant advancement in CT hardware, with manufacturers have made from multi-detector scanners to dual source scanners and spectral CT scanners, and recently the admission of photon detector CT scanners has significantly improved the imaging world. And also new software and new AI tools have added to the CT's resolution, making from high to ultra high to super ultra high resolution, which has enabled us to actually look at these imaging biomarkers in cardiac CT, which are measurable indicators that may predict disease outcome and improve diagnostic accuracy. So AI algorithm has really improved the speeding up of this process, greater reproducibility, and also fast labeling. Now, deep learning has literally revolutionized CT imaging as you know, by improving the image segmentation, quantification of plaque extent, and stenosis assessment, that's the most fundamental application of machine learning analysis. Now, plaque characterization and also stenosis assessment, as we discussed before, identification of culprit coronary lesions, and calculation of composite scores, and of course, FFRCT. So these are all actually helped by AI. So in AI, basically the core of AI is the foundation model, and then deep learning and machine learning, and that's how the artificial intelligence. So foundation models these are large data which are trained, and then they are adapted to actually give us the task we want to actually achieve for them. In AI, actually, if you look at this, there's a second, this thing went down. There's a 9-level technology readiness scale on AI for the readiness of maturity of the level of AI tool, from research development to deployment. And look at here, most of the deployed softwares in AI are actually in CT, in deep learning reconstruction, deep learning in functional flow reserve estimation, and plaque assessment, and also cardiac functional analysis, and CT and calcium identification also. So where we see mostly application is in the reconstruction now, improve quality and dose reduction, which is really amazing how it has decreased the dose by using AI in these things. Again, calcium reproducibility quite a bit, coronary plaques detection, and also characterization. Again, motion correction also have some software to do that, and epicardial fat, which is really a marker also for prediction, and of course, FFRCT, which is a low computational burden on that. So most of the applications are used in coronary CT, in coronary stenosis and FFR, and then we have in calcium score, and then prognostic prediction and image reconstruction, and epicardial fat, and motion correction. So here we see the new machines that come out, and now from 0.6 resolution gone down to 0.2. So really you improve in the blooming artifact, which was one of the really biggest problem in cardiac CT initially when it came in, and that has significantly improved. And so is the reconstruction method. Now we have hybrid iterative reconstruction with deep learning, and you can see the resolution has gone significantly, has improved significantly, you can see, and that's why we can see the plaque really good. So what in plaque characterization, as you know, plaque has there's a whole shades of gray from low attenuation fat all the way to calcified plaques. So these shades of gray, they're almost close to 200 shades of gray actually, which AI can see, but human eye can only see 40 or less than 40 shades of gray. And now I know some of you guys are thinking that your eyes have seen 50 shades of gray. I understand that too, and I have seen that too. But we're talking about AI, which can see a lot more here. So this is the schematic representation of a whole number of plaque, which you have seen. I mean, every meeting, you see, you've seen that there's a necrotic core, you see hemorrhage, you see spotty calcification, necrotic core, and you see the fibrin cap here, and that's the lumen, and then there's a neovascularization. That's where the extra and the vessel wall remodeling happen. So in getting this high resolution, now we can actually image most of the stuff, and you can see spotty calcification is one of the sign of feature also. That's a spotty, that's a lumen here. This is the schematic you can see here. Again, napkin ring sign you can see in the lumen, and see the schematic here. Low density or non-calcified plaque you can see, and also external vessel wall remodeling. So all these features you can actually see and characterize them. So there are many studies done, AI-assisted atherosclerotic evaluation for the cardiovascular risk assessment, and where they really see the plaque characteristic, especially in symptomatic patients. So the iconic study, as you see here, is showing us quantitative evaluation of total coronary tree, that low-density non-calcified plaque and high-risk plaque and severe stenosis were associated with higher risk of acute coronary syndrome. Now, PROMISE study has also shown, and although it does show that significant stenosis was associated with 9-fold increase in MACE, but if you adjust the stenosis and the cardiovascular risk, then you can see the plaque will show you the patient presence of high-risk plaque was associated with a modest increase in adjusted hazard ratio. That means high risk of coronary, high risk of adverse effects on these. Now, this is Scott study, Scott-1, Heart-1 study, which showed that the low attenuation plaque was independently associated with MI. And that is very significant finding. If you look at this, is a low attenuation plaque here, you can see it right there. If the patient has more than 4% increase in non-calcified, burden of non-calcified low attenuation plaque, there's actually 5 times more likely to have subsequent MI in these patients. So this is all by looking at the plaque characteristic. Scott study 2 with deep learning plaque analysis showed that after you adjust all the other factors, a total plaque volume of 238.5 millimeter cube or higher was associated with increased risk of MI in these patients. Again, the plaque characterization is telling us something. AI-guided plaque and stenosis guideline in a new study that's recently done by Noor Muhammad. He followed almost 10 years follow-up in these cases. It's very interesting. It showed the stage 3 plaque based on plaque atheroma volume was associated with composite outcome of adjusted hazard rate of 3.5. So that is quite significant, thing. And you can see here in the graph also a picture, patient who have plaque atheroma volume greater than 15% have a higher risk of 10-year cardiovascular risk increase in these patients. And these are all the studies that show their different plaque characteristic in these patients. And of course, the coronary stenosis is one of the top in these things, which will tell you the risk of MACE in these patients. And newer study also by Noor Muhammad also showed that AI QCT ischemia model using coronary atherosclerosis and vascular morphology characteristically accurately diagnoses coronary ischemia when you correlate with invasive FFR, and also is better than perfusion SPECT study also. Again, the other one also have shown that the plaque morphology, non-SPECT morphology can also be assessed through this also, and you can find the lesion-specific ischemia, which are significantly hemodynamically significant lesions too. So all these studies have shown just by looking at these quantitative and characterizing the plaque structure. And here's also just recent study came out, which is a 5-year follow-up. This was core 320 study where it shows that QFR, CT QFR also correlates well with the ICA and SPECT with positive and negative for 5-year prognostic value of it almost predicts the same as done by ICA and SPECT, except if patient has prior PCI. So now let's talk about, we've talked about the other thing, let's talk about the FFR. So functional flow reserve CT is becoming really a tool for accurately identifying flow limiting coronary disease. That's very common in our practice also and other places too. I think that everybody's trying to use that to make the right diagnosis and to see what we have to do next for the patient. Many ways to compute that. The computational flow dynamic model, which was a mathematical model, simulation of coronary flow, pressure, and resistance, provides an accurate, non-invasive way of accessing the stenosis. So, but the deep learning FFRCT model, which is interesting, we use multi-layer neural networks and recursive neural networks, as you see here, and encodes all the structure and functional characteristics of coronary and gets you to the FFR at each point on the coronary tree. Now, multi-center machine registry found no significant difference between deep learning-based and computational flow-based FFRCT in terms of diagnostic performance, but it significantly reduces the rate of unnecessary invasive coronary angiography. And as you have seen in the platform study showed that platform trial. And also there's a 100% negative predictive value for excluding any major cardiovascular effects in patients with acute chest pain for at least for the next 30 days. So very high predictive value. So leading to all this thing led to all this validation led ACC and American Heart guidelines to actually recommend as a frontline CT and FFRCT. And it has been shown in all the different trial, but precise trial showed that there is actually quite a bit of CT and cerebral pathway resulted in a lower rate of major adverse cardiovascular effect compared to usual care what we do in these patients. So the clinical value is between, when you have stenosis between 40 to 90%, it really helps you avoid more than 60% invasive procedures and reduces 30% of the cost. So patient comes in, gets CTA, FFR, if the stenosis is 40 to 90%, you do CT FFR if more than 0.8, which is considered normal range. Above 0.8 is normal, so you don't need to do anything. But if it's less than that, then your patient goes for the invasive angiography and further treatment planning. So DeepVessel FFR is actually software which is a product of Kia Medical, which is a global medical technology company specializing in deep learning medical devices in coronary artery disease. So their flagship product is DeepVessel FFR, which is a CT-based FFR analysis, and it has been FDA cleared. As you see, in 22 it has FDA, and all the other regulatory agencies have also cleared it too. And the product in pipeline is also Cardiovascular, which is a DeepVessel plaque analysis, and we'll talk about that a little bit. So this is just a DeepVessel FFR, which is perform non-invasive physiological function assessment of coronary arteries using CTA. And the reports are generated in 3D interactive way, and also FDA report is given. So you upload this is how it works on Intelerad Ambra healthcare workflow. So you upload in a secure portal your CT images, and goes to the DBFF algorithm platform where its analysis is performed, and you get the result in 3D heart model and also PDF report electronically in. So many studies were done for validation of study 2017, 19. They all showed really good accuracy and sensitivity and specificity of CT FFR in correlating with the invasive FFR. This is a international multi-center trial, was for FDA clearance. You can see 5 centers were here and other in Europe and other areas. The study showed really good for the FDA clearance and good sensitivity of 95% confidence range into 87.4 and 73. It was really very easy to pass that FDA clearance. So this is another targeted randomized trial, on-site FFR, which actually tells you that on-site, even this is a controlled randomized study, showed that it can improve the selection of patient for invasive procedure by identifying those who are more likely to have obstructive disease for revascularization. So the technical characteristics are really, it uses DeepVessel FFR, uses less computational power, performs analysis in minutes. So it's very, very fast, actually. It's less than a minute in some way. Improves performance with more data. So more data you put in, it actually learns more and more, and the results get better and better. And it's also compared with the computational flow dynamic heart flow also, and the results are very, very comparable with that. So it tells you that it is really comparable device. So DeepVessel FFR, I'm just going to do a couple of cases for you. This is a patient who had cardiac CT and showed 70% stenosis in this patient, and went for ICA, invasive FFR exam, which showed 0.88. But they did retrospectively, and they said they did DV-FFR on this also, which showed 0.87, almost quite similar results there. So this could have been avoided if DV-FFR result was used to assist that. So this really becomes I would say it becomes a gatekeeper for invasive coronary angiography if you use DeepVessel. So another case, shortness of breath, echo had abnormal anterior and lateral wall motion. You can see that's color-coded. The reddish color is a more severe abnormality, and you can see it's 0.52 FFR of this in the circumflex, and also in the other one is also slightly lower than that thing. So this was again, and you get the result just like in PDF also, and also correlating the CT image at the same time too. And another patient here, which is left arm pain, tingling, positional dyspnea, abnormal. See multiple vessels or abnormal. You can see in the cath also. And this was actually, they were taken for, decided to have bypass surgery in this case, in this patient. So you can actually measure anywhere you want in the tree. You put your cursor, and it also gives you the diameter of the vessel also where it is. Actually, that's also nice to see that. It's another case which RCS significant stenosis here, and it's down to 0.7, 0.51 FFR, which is really abnormal in this case. So machine, also we have seen in that you can actually predict acute coronary syndrome with kinetic plaque features, which is if you do serial coronary CTA, you can actually see the dynamic changes in the plaque and predict the risk of acute coronary syndrome. Now, if you have all these features in the cardiac core, remodeling index, plaque volume, calcium, and this all improves the risk, or you can predict the risk of acute coronary events in these cases. So now they have also come up with the DeepVessel plaque, which is a flagship product, and it should be out soon after the regulatory approval here. What it does, it's actually a workflow platform. It's called CardioSight, and you have stenosis report here. Currently, you also have DeepVessel FFR, and you have plaque also. So all these. So here's one example of stenosis analysis. You see this color coding. It tells you, it gives you the really a plan and a diagram schematic where the lesion is, and it correlates with exactly where it's on the CT scanner also. So color coded severe would be red, and orange, and that's how it goes down. You see these. And now they also have plaque analysis, which you can actually see that it gives you all calcified plaque, non-calcified, and low density plaque. These are all very important, that's why. And you can get the volume also of these in these individual vessels also, and completely. So you can actually get the whole atheroma, whole plaque quantification and characterization. So talking about the next, the marker is actually quite a few papers are coming on fat attenuation index, which is perivascular, pericoronary artery fat attenuation. And it actually measures that. And the more the fat gets stranded, more dirty it gets, it means that there's more inflammation in the coronary vessels. That is one of it's a marker to assess inflammatory status of coronary blood vessels, and increased perivascular fat may be associated with higher risk of coronary cardiac death and poor clinical outcome. As you can see, it's been measuring it. So they say actually -70 is more than -70. It's significant. It really is. A lot of studies are coming out how you do it. And this just came out fresh from the one last week, actually a week ago. But it shows incremental prognostic value of pericoronary adipose tissue attenuation in patients with diabetes and coronary artery disease. And you can see that's independent predictor of MACE in this case, who have perivascular fat attenuation in this case. And you can see, you can measure this thing. So that is another thing we have to actually look in the biomarkers. So AI-derived decision-making and assessment of coronary. I actually would add to that AI-derived or AI-assisted, because you are still the driver, okay? So it is AI-assisted. Traditional risk scores, as we know, have limited accuracy of predicting MACE, but AI solution has contributed to all steps of cardiac imaging, images, workload, accuracy, and less variability. So advancement has improved our quantification and characterization of plaque. I really like the characterization of plaque because that tells you a lot, as you saw in the studies we have presented. So multi-center trials have proved the prognostic value in the population, not just one, but the whole population. So when you combine coronary CTA and FFRCT with risk markers, you may improve, major adverse cardiovascular event. And also quantitative imaging now is, the techniques powered by AI and machine learning are really shifting towards personalized data-driven treatment plan for coronary artery patients. So we are moving from population to individual also, like customized, treatment plan, like they're doing exactly during cancer. They're moving and getting to personalized treatment of that particular cancer, because there's so much heterogeneity in pathology that you have to really focus on personalized. Some people need slightly different. I appreciate your lending me your ears. Thank you so much. I would now, I think I will move to my friend and colleague, Dr. Armin Zadeh, to present his talk, which would be management of patient with stable coronary artery disease. And his thing is AI ready to help? Thank you so much.
Yeah, thank you very much, Irfan, for allowing me to serve on the panel here, and congrats on this nice overview of a lot of data. So there's a lot of things going on, and there's a lot of excitement about the technology. There's no way, no question there. But at the end of the day, we have to look at how the technology is going to help us for the management of our patients. So I'm going to, the next few minutes, I'm just going to remind ourselves of the main job we have to do for the management of patients with coronary disease. So here are my disclosures. So essentially, the goals of management are pretty clear. So it's improving of event-free survival foremost. These patients are at risk, and we want to mitigate their risk. And secondly, it's symptom control. So patients who may have angina, etc., and we want to improve their quality of life. And the tools we have, essentially also quite confined, limited, essentially. So we have, first of all, optimal medical management and risk factor modification as the mainstay of therapy. And then in addition, in a subset of patients, we have revascularization as an option. So the idea, at least in theory, is that many of these AI tools eventually allow us to risk stratify further, because particularly optimal medical therapy at this point encompasses a wide range of options. And it's likely that these options will further expand. And then the question is, which kind of options will be optimal for which patient group, and particularly, in terms of the risk-cost balance, would be optimal for a specific patient. So there's a potential that we can further, help, in having, a more granular assessment and therefore more tailored therapy for patients. But we're not quite there yet. And the other question is whether we can identify patients who would benefit from revascularization, using some of these tools. Now, at this point, I want to point out, though, that we are still not even doing well in terms of what we are doing or what we can do at this point. So I always like to highlight that in the ischemia trial, only 20% of patients enrolled, at the beginning, were at target for very basic optimal medical therapy targets, which is LDL control, blood pressure, smoking cessation, and aspirin. Only 20%. I mean, this is really remarkable, how miserably we are failing, providing these essential treatment to patients, to the extent that we are, meeting goals. And with the intense, efforts during the trial, 40% reached targets, which is, again, obviously still leaves the majority of patients, short of these targets. So again, the point here is that we cannot forget, that we are, currently not even providing optimal medical therapy, to most patients even though these interventions are clearly associated with reduced risk of adverse events, with prolonged survival. So what I'm saying is, we're focusing already now on tools, on AI methods to identify specific subgroups, but at the current time, we're still not able actually to provide the best care for the patients with the tool what we have. Now, what are the major drivers of risk? This is pretty clear at this point. The coronary atherosclerotic disease burden is by far the most important driver of risk. These are three major cohorts: a high-risk cohort in a cath lab. This is a intermediate risk group from CT imaging, and this is a very low-risk group assessed by coronary calcium scanning. And essentially, they all show the same thing. They show on the y-axis here the risk, cardiovascular death or MI risk annualized versus some form of atherosclerotic disease burden assessment, like in semi-quantitative fashion. And in all of these curves, they're showing essentially a straight line. The higher your atherosclerotic disease burden, the greater your risk. So that is, consistently, uniformly true. The atherosclerotic disease burden drives the risk, by far the biggest predictor of risk. At the same time, we also have to keep in mind that ischemia has lost significance for prognosis. The ischemia trial nicely showed that this is here higher risk versus lower risk according to whether you had moderate to severe ischemia versus none or mild. And for all these endpoints, if you adjust for the coronary atherosclerotic disease burden, there's no evidence that ischemia has any independent predictive value. So that is very, very important to keep in mind, and it's difficult to convey because for the past decades, we always have been trained to kind of think about ischemia, but ischemia really does not have an independent value in stable disease for prognosis. So that these pieces of information are critical to inform us in terms of not only risk stratification, but also management. So what we need to do is to identify patients with coronary atherosclerosis, A, and B, we need to kind of have some assessment how extensive that atherosclerotic disease is. And the importance of that really became very clear in these studies comparing CT with stress testing in these large studies. And because all of them showed that the risk of myocardial infarction or the risk of MI or death was lower in patients assigned to a CT strategy versus a stress testing strategy. And why is that? Because CT is much more sensitive to identify patients with coronary atherosclerotic disease, or vice versa. Stress testing is quite insensitive, misses a lot of disease. And if you identify patients with atherosclerosis, you then be able to provide medical therapy, which then leads to lower risk. So again, the key notion to identify patients who have atherosclerosis can really not be overemphasized. And this applies to millions and millions of patients being scanned every year. So what I'm saying is the low-hanging fruit is just to have a greater application of the tools that we have, because currently, according to most recent data, only 10% of patients roughly undergo CT, 90% still undergo stress testing when they come for evaluation. So we're missing the opportunity in a huge population to identify them as having coronary atherosclerotic disease and then be able to provide preventive measures. So instead, we're still kind of like looking for the holy grail and for the next best thing, again, missing the opportunity here to do something at the same time while we're here in clinical practice. Now, I don't want to minimize our excitement for technology. Again, there's a lot of, as Irfan showed, a lot of very, very interesting developments. This is data from the Irfan study published in Lancet last year, showing that they're with a AI risk assessment tool, which encompasses a lot of different metrics, including clinical predictors, plaque burden, inflammatory information, using pericorneal adipose tissue attenuation. They're using what they consider high-risk features, and they put it together in a proprietary assessment, and that seems to predict cardiac death in this case better than just the baseline assessment of clinical predictors, even in the presence of obstructive coronary disease. As you can see here, quite remarkable additional hazards with the high-risk classification by the model. So this is exciting, has to be confirmed. And the question again is, how does it help us to manage our patients? Because we have to do the next step too and show that this information translates in specific management steps, which then lead to better patient management. And that has not been done. At the same time, there's very conflicting data. This is another AI algorithm applied to the ischemia trial, and it showed that compared to a basic model of clinical predictors and just the number of disease vessels, the incremental predictive information for adverse events, it was myocardial infarction and cardiovascular death. Again, total plaque volume was the only significant predictor, independent predictor. Again, it always comes through for you that total disease burden is the biggest, strongest predictor. Importantly, some of these advanced features, such as low density non-calcified plaque volume, so-called vulnerable plaque, was not predictive, independently predictive. Number of high-risk plaques, not independently predictive. Remodeling index, not predictive. So what I'm saying is, there's still also a lot of conflicting data in terms of the utility of some of these features, even before we have tested them prospectively, according to their value for patient management. So we're getting closer, but we're not quite there yet. At this point, we're still fairly limited in our assessment. The key thing, again, is to identify patients who have atherosclerosis. The CT should be the first-line test, I believe, in all patients with suspected coronary disease, rather than a stress test. If you have no coronary atherosclerosis, you have exceedingly low risk, and you can focus on lifestyle modification. Whereas if you have atherosclerotic disease, the key thing is to do optimal medical therapy and just do better than we currently do, because that really makes a big difference to patients. Question is in terms of who is still benefiting from revascularization. Current area that is an unresolved question, because there was no such group in the ischemia trial, even among highly selected patients. Left main disease was excluded, so we still believe left main disease may be a high-risk feature. But that is an area, again, where advanced tools, such AI tools, may help us identifying patients who benefit from revascularization. Currently, we don't have that. Now, last minute, I just want to also make sure we're talking about symptom control, and I just want to highlight two things. Ischemia is a poor predictor of the severity of angina. So it's again shown in the ischemia trial, a little busy slide, but essentially severe ischemia here is in red, and then moderate in orange, and mild here in yellow. And compared to the severity of angina, no angina monthly, and then probably fairly extensive angina on a daily basis. The point here is these numbers are all very similar. So patients who had no angina had almost as much ischemia as those who had severe angina. And that really shown for patients with obstructive as well as non-obstructive disease. So again, the key notion to take away here is that the correlation between angina and ischemia is very poor. So meaning that if you identify a patient who has an abnormal FFR, let's say like 0.7, etc., does this patient benefit from an intervention? And the question is, not necessarily. If the patient does not have angina, the benefit of it is symptom relief. The patient does not benefit if the patient does not have angina. And the other important point I want to highlight before I close here is that the vast majority of patients have either no angina, meaning of patients who have stable coronary disease, or infrequent angina. So particularly in the heart and soul and appeal large registries, 90% of those had either no angina or very mild angina. Then the quality of life scores, 100% is basically perfect. There are 90 in these. So meaning that patients in general are have very few and not limiting symptoms, which kind of, again, needs to we need to put in perspective in getting away from, looking at a number 0.8, obviously it's just one piece of the information. And again, an FFR 0.6 doesn't mean that patient will necessarily benefit from revascularization. Okay, so in summary, the outcome of patients with coronary artery disease really depends on the presence and extent of coronary atherosclerosis, and the role of ischemia has lost significance. We cannot forget that medical therapy is the key treatment, but it remains underutilized. But there is possibilities of further risk stratification with AI. But at this point, we're lacking data for specific recommendations. So I'm closing here, and we're going to move on to some case examples. Now, we have some questions and recorded questions from the audience, and we will address a lot of these questions, most of those at the end in the panel discussion. But for the purpose of moving forward with the schedule, we're going to have a few cases and then open up for the group discussions. So I'm happy to pass the baton to my dear colleague Mike Blaha.
Great, thank you. I'm going to try to be brief. I have a little bit of a case and then a little bit of a discussion. And I'm a preventive cardiologist, also a CT angiographer. I want to shift the conversation a little bit as well to coronary calcium and as it relates to CT angiography and how artificial intelligence plays into primary prevention thinking. Just a real quick reminder, of course, generally we're using the coronary calcium score in primary prevention because it has a 2A recommendation in the broad borderline to intermediate risk group. And I want to show you, though, two cases that have the same calcium score. These patients both have the same calcium score of 200. And we're going to ask, is there a difference between these patients, and what does that tell us about plaque and risk? So here are the two patients. You can see the patient on the left has got dense focal calcification in the LAD. The patient on the right has got more diffuse, less dense calcification throughout several of the coronaries. And you can see these patients are different in several different metrics, but have the same calcium score. Their area of calcium is different. Their density of calcium is different. The distribution of calcium is different. If you were to look at the pattern of calcification, it's different. The number of individual lesions. And also the lesion type is different. So one of the questions we're going to ask is, well, what is the plaque correlate of this? And then can AI tell us more about even patients in primary prevention in the future? I'll just go through this really quickly. Many of you know that your risk goes up the more calcium area you have, but it actually turns out your risk goes down the denser your calcification is, suggesting more stable plaque. Also, we know that the more diffuse your calcium is distributed throughout the coronary tree, the higher risk of a patient you are. We actually know that if your calcium is within the left main, it more closely predicts all-cause mortality than if it's not in the left main. We also know that the number of lesions and lesion size are predictive too. So there's actually a bunch of information baked into a standard calcium score that we don't use that predicts risk. So the question is, where are we headed in the future with either a new calcium score or maybe one that's interpreted by an AI tool? So is there a role for AI-based calcium scoring? And how can we improve upon the simplicity and effectiveness of the calcium score? So really is the answer non-calcified plaque, some measure of high-risk plaque. Now, I'm not going to cover this in detail, but as you may know, if the calcium score is really high, you actually have the risk equivalent of a secondary prevention patient. And even in the new ACC expert consensus decision pathway. It says if your calcium score is above 100 or above 1,000, we're going to shoot for very low LDL goals. So probably the answer is, or at least some of the question is, can we improve upon plaque assessment in those patients with very low calcium scores or even no calcium? And very quickly, I'm going to talk about zero calcium scores and CT angiography in the future of AI. This is the idea of the calcium score of zero. I'm going to show you two population-based studies that looked at CT angiography in healthy patients in the community. This is Scapus from Sweden. What I'm showing on the right is what you see on CT angiography in patients from the community with a calcium score of zero. You can see that about 6% still have a little bit of atherosclerosis. Only about 0.4% have a stenosis. Now, 4% of patients have exclusively non-calcified plaque. So not a lot, but there's some patients still out there with some plaque. This was from the MyHeart study. Looked at about 2,400 patients, again, from the community recruited. They all had CT angiography, and at the bottom of the patients with a calcium score of zero. Here they saw up to 15% of patients had at least some non-calcified plaque. Only about 0.8% of patients had a stenosis. Now, 2% of patients had what we would call high-risk plaque. Now, I'm just going to end here and say, well, what's the future? This is when, in that same study, some unpublished data, if an AI-based tool is used in that population-based MyHeart study. And in blue, the calcium score of zero, for example. And you can see, at least using an AI tool, we'll have to see what the outcomes are. You identify more positive remodeling, more low intensity or low attenuation non-calcified plaque than if we use our standard visual interpretation in these patients with a score of zero. So the question I'm posed that we can discuss at a later time, perhaps in the questions, is an AI tool going to help build a better calcium score or help us find better estimates of non-calcified plaque or high-risk plaque, even within the group that we would generally call relatively low risk? So that's what I'm thinking about in primary prevention these days. So with that, I'm going to close, and so we can save some time here. I'm going to then pass it to my colleague, Dr. Dinesh Kalra, who's going to talk about some cases and talk about plaque and where that fits in the CAD patient.
Thank you so much, Dr. Blaha. And I have a couple of cases that I want to go through real quickly to emphasize the learning points that we've seen so far. So case one, 70-year-old white man who was referred for dyspnea and exertion. He's obese. He's got hyperlipidemia, diabetic, ex-smoker. And you see his lipid profile is fairly abnormal with an LDL of 126, triglycerides of 260, HDL of 30, while he's on atorvastatin 10 milligrams. And so we did a CTA to rule out what we call ischemia equivalent, but really to quantify his atherosclerosis burden, which, as you've heard, is the more important marker of prognosis. So this is not yet FDA approved. This is stenosis by AI using Kia's tool called DeepVessel FFRCT. And you'll see this tool being offered by many of the AI companies. And what it really helps you do is you're going to do the manual read yourself, but it sort of color codifies for you where to first focus your attention. So if you see what AI thinks is a moderate or worse stenosis, then you would perhaps want to interrogate that area more carefully. So here you see that there's only minimal stenosis in the left main and LAD and circumflex, and maybe mild to moderate stenosis in the RCA. And then you do a DeepVessel FFR. This product is FDA approved. And the reason to do this, as you've seen with Dr. Shafique's slide, is if you have an intermediate stenosis, you can interrogate all three vessels, especially the ones that are 40 to 90% stenosis that may be symptom producing, to look for lesion-specific ischemia. So this patient had no FFR values, non-invasively derived, that were less than 0.8. So there are no ischemia-causing lesions here. But more importantly, we're focused on plaque burden. And if you look at the amount of plaque, it's relatively a lot. So, there's different gradings of plaque. So less than 250 millimeter cube of total plaque in all three coronaries. And you quantify that using AI by drawing the inner lumen and outer lumen of the blood vessel, and then looking at the densities, and the AI algorithm automatically assigns for you what is calcified plaque, typically more than 350 Hounsfield unit, or soft plaque, or low attenuation plaque, which is less than 30 is low attenuation, and they'll add these up for you and give you a total plaque burden, which in this case is more than 750 millimeter cube, is severe. So this gentleman has 1100 millimeter cube of plaque, of which the low density plaque is about 190 millimeter cube. That's a lot. And so you get an idea of plaque distribution in all three vessels. And so you now know that this gentleman has 3-vessel diffuse plaque. And as we've heard, that has an independent prognostic value. In fact, in 2 of the trials, PROMISE and SCOT-HEART, the presence of non-calcified plaque, which is felt to be the more unstable plaque, had a hazard ratio of about 4 to 6-fold in short to medium term MACE events. And so that information beyond stenosis becomes really crucial in managing your patient. As Dr. Blaha has mentioned, looking at where the plaque is and the diffusivity of plaque and the type of plaque, but more importantly, getting an idea of how much total plaque burden is there can help you not just prognosticate, but then see what are you going to do for therapy. So this is what we did in this gentleman. We increased his atorvastatin from 10 to 80 milligrams daily because his low attenuation plaque is more than the 4% that you had heard of in SCOT-HEART that worsened the prognosis. His was 17%. So went up on the statin. We added PCSK9 as the expert consensus document would tell us on non-statin therapy. I would argue his goal should be less than 55 for LDL, given the multiple risk factors. Added icosapent based on REDUCE-IT trial because his triglycerides are more than 150. Added a GLP as well as an SGLT2 because he has HFpEF and diabetes. And we know these drugs are not just atheroprotective, but also help in heart failure. And lastly, as you saw, added aspirin based on 2 documents, one which was from Dr. Budoff that Dr. Blaha mentioned, where if you have a calcium score of more than 300, it is equivalent to secondary prevention. And so this gentleman may benefit from aspirin also. If I have time, I quickly want to go over one other case. This one's relatively simple. We had a middle-aged woman with chest pain, hyperlipidemia, diabetes, and we went ahead with CTA, which is class 1 level of evidence A, as all of you know. She had mostly soft plaque in her proximal LAD, so she got a CAD RADS of 4A. Plaque burden was P2, which means mild to moderate, and there was couple of high-risk plaque features. One was that she had positive remodeling and another region at low attenuation plaque. We proceeded with FFR in this woman, again, using DeepVessel, and the 2 centimeters beyond the lesion that we saw, the FFR was 0.79, so borderline. And she proceeded for angiography because she was still having symptoms, and that confirmed on adenosine FFR a similar value as we saw non-invasively, and that was fixed with stent. So those are the 2 cases I have. I'll stop here and I'll pass this on to Dr. Zadeh, who will now answer your questions.
Yeah. Welcome back. Thank you. Great talks. Armin is looking for all the questions coming in. Meanwhile, I have some questions we can ask. We pulled some questions here too. And while he's looking for the questions, let me ask.
Sorry. Let me ask you, because before we get to, I want to make sure we can address the audience questions because there are so many of them, and we're running out of time. So one question, was, and that's guess for all of us, what is the single greatest way, we feel that artificial intelligence may impact our work, has impacted our work, and will impact our work? So it's obviously a broad question and a very exciting question. And maybe, Irfan, you want to start with that, answering that?
Okay, you put me on spot here. So one specific thing, I think, what is one single thing? Is that what you're asking?
Yeah. So what is the, how do we feel that AI specifically impacts our work in what way particularly? right now and in the future. So
Yeah. So I think it's a great question as we're all going through it. It's just a start of it and we're getting through this. But I have found a few things which are, I think one is that on one hand, it does increase the efficiency. On the other hand, there's a lot of, butterfly in my tummies too, I'm still trying to get used to this thing, but it has significantly increased the confidence now as I'm getting more and more involved in those things. And I feel that, especially, let's say FFRCT, okay? Like once in 2 weeks, you'll see one case which is totally throws you off. And it says normal FFR when there's really severe stenosis. And on the same way, they'll have the other way too. It's like not much stenosis, but the FFR is really abnormal. But now I've seen that the studies have shown that there are cases which will show this way, and those are real. You have to look into it. And as you specifically, you mentioned that there's no really much correlation with angina and ischemia there. So I'm always not concerned of these things. So it definitely helps increase the confidence also. And I think you can say definitely that this 50 to 70% lesion is functionally significant. You can say quite that they have to move forward to do further or stop or be a gatekeeper. The patient does not move forward. So
okay,
yeah,
so
it's
diagnostic
helping quite a bit.
confidence. Sorry, the diagnostic confidence is the what you feel there's the biggest contribution. Dinesh, what do you think?
Yeah, I think, I'm reminded of this phrase that someone, we have a center of AI here, and we always talk about, AI is here. And the clinicians who are going to do well are the ones who are going to learn how to incorporate AI in their day-to-day life. And that's what the question's asking. So for coronary CT, I think we have amazing amounts of data. So beyond stenosis quantification, right? We all can do that easily. But where does it help you? Plaque quantification. Who wants to spend 4 hours quantifying plaque? And if you can get that information in 1 minute, especially things that are hard, like low attenuation plaque, I would be hard pressed to go around looking for the -30 Hounsfield units. But those are the plaques that may confer a higher risk of MACE. Pericoronary fat attenuation, which I can't do with my eyes. I need software to do that. Same thing for CT-FFR, which is in daily use these days to guide future management. I think all of these technologies are here and present. And like you said, they increase diagnostic confidence. They help you manage patients. But what remains to be done is someone asked, long-term post-marketing details. How often are they incorrect? Because Hounsfield unit depends on what KV you use, what protocol you use. How do the companies, correlate with each other in terms of the plaque burden they're giving you? I think those are the things our field has to still do, but the future is exciting.
Mike.
Absolutely.
Yeah, so great answers. I agree completely. I particularly like the notion of the high-risk plaque, the low attenuation plaque identification in a more consistent way. Just because I'm a preventive cardiologist, I'll toss another one out there. I think AI is a tool to instantly read calcium calcification on non-gated chest CT, that we see 10-fold more chest CTs for other reasons than we do for cardiac CT. So bringing more patients into the fold who we can assess their plaque burden, maybe perhaps incidentally at the time of their chest CT. We don't want to be, we've already heard from our colleagues, we don't want to be spending a lot of time on this. But if an AI tool can make this reproducible and quicker, this could be game changing. So I'll leave it at that. That non-gated chest CT is another great application of AI.
That's excellent. I think that's one question for you. Do you have any other question? I have one question for Blaha. Quick one. What do you think is the role of calcium scoring in the era of statin, because, serially, can you do, and what's the really incremental value here?
You mean if the patient's already on a statin?
Yeah.
Yeah, we still do it in that situation if it's going to change our management. This happens more often than you might think. Patients comes to you to see you, and they're on let's say a low intensity statin, and their LDL is, let's say 100. It's not bad, but it's not real low. I would do a calcium score there because I don't know if I'm treating a patient with an extensive amount of plaque that I really need to get that under control, or I'm treating a patient with, let's say, no or minimal plaque, where maybe an LDL of 100 on 10 milligrams of pravastatin is fine. Also, I don't know if they should be on a baby aspirin. I also don't know if they need non-statin add-on therapy. So I still do the calcium score, even in those patients treated with the statin, realizing the statin will creep up a little bit, the amount of calcified plaque, but it's still, in my opinion, interpretable and actionable.
Great. Thank you so much. I think we are almost, we have a lot of questions here, but we will certainly answer them offline. Do we have any more time, or we are done with the time? I just wanted to ask Candace, is there, or can we take one more question, or are we done with it? Looks like we are out of time now. But anyway, thank you so much, all of you, for joining us today in this on this platform. I wish we had more time to discuss a lot of things which were still hanging there, but we will certainly answer a lot of your questions if you have put it on the QA. I want to thank FSCCT to providing us the platform to do this educational program, and definitely their staff also, and also thank Kia Medical for really sponsoring this educational program. And absolutely great thanks to all my panelists who joined me on this endeavor, and absolutely thanking all the attendees for lending their ears and taking their time during the middle of the day to listen to this talk. Thank you so much, and hope to see you next time. Thank you again.